You examined the use of FDG-PET as a prognostic marker for progression-free survival in patients with relapsed follicular lymphoma after induction therapy. Could you explain the rationale of the study?
Well, this was a sub-study of the Gauss trial, which randomized patients into rituximab and GA101. And in that, GA101 was expected to induce more inflammatory tumor response because of its enhanced ADCC and direct cell killing mechanism. And we were expecting to find a difference between the two groups. And one group would be less predictive maybe for PET because of the higher inflammatory response. And also, in parallel, predictive value of PET with respect to progression-free survival has never been studied in a relapse setting in follicular lymphoma. All data exist in first-line end of induction therapy, and that would be a good guidance to the clinicians if they wanted to modify treatment for patients undergoing therapy in this population.
To assess the effectiveness of FDG-PET in this setting, you used 3 different criteria. Could you summarize how you studied this?
Well, in those 3 criteria, the first to visualize, basically based on visual assessment, IHP criteria and Deauville 5-point score criteria, and the third one is more quantitative based SUV change based criteria, EORTC criteria. So the first 2 were in a way heavily used in lymphoma, but the third one has not been developed for lymphoma, has not been validated in lymphoma. We were curious as to what results we would get if we used those criteria in this population. And the IHP criteria, again, which is now incorporated in revised IWG response criteria, were originally developed for end of treatment assessment and Deauville 5-point score for interim PET assessment. So again, never been applied to a patient population relapsing follicular lymphoma setting. So that would be an interesting scientific endpoint.
What were the most important results, and did you find meaningful differences between the different methods?
Well, interestingly enough, the visual criteria compared to ERTC did better. And between the IHP and 5-point score, no differences were found, and they were 100% concordant. And the EORTC criteria versus visual criteria were concordant only in about 50% of the patients. That was sort of expected because, again, EORTC criteria were not validated in lymphoma, and the cutoff points, mainly 25% change it relies on in SUVs, not necessarily high enough to find a meaningful difference. In a lymphoma setting, which is a very chemo-sensitive tumor, maybe in solid tumors more relevant if they are applied, not in lymphoma, because lymphoma you are really looking into more than 50% SUV change to translate to a clinical meaningful progression-free survival.
How does this knowledge affect physicians in clinical practice?
Well, at the end of the day, as a secondary or a tertiary assessment analysis, we did look at the ROC curve defined SUV cutoffs, and 60% decrease in SUVs led to a better assessment, not necessarily that different from visual criteria, but still better looking in terms of confidence intervals and p-values and hazard ratios. So maybe cautiously optimistic for % change in SUVs in relapse follicular lymphoma. In that, if we can validate that point with larger sample sizes, clinicians in relapsing lymphoma may use that cutoff to modify their management, either change treatment in the mid-course after induction therapy, or abbreviate or enhance, escalate treatment. So they can modify their management. But still, it's too early to say that. We have to be cautious. These are low number of patients. We cannot claim any surrogacy for PET, especially for quantitative PET. But it is promising.
And how can these results be used in clinical trials?
Again, the clinical trials can be designed according to the cutoff of SUVs, or again, visual criteria. So in the, especially adding PET to conventional response setting or criteria, further categorize patients in the stable disease and partial response groups into different prognostic groups. So if you add PET, you will find a better survival in those who are negative and worse survival in those who are positive. And that may randomize or adapt patients into different therapy groups in clinical trials.